asset. So Melly, if you could start the recording. So good morning, everybody. Good afternoon to our friends joining from Europe. It's a real pleasure to introduce Professor Stefan Windecker for our Monty-Hart Grand Rounds. For those of you who don't know Stefan, he's the chairman of the Department of Cardiology at Swiss Cardiovascular Center in Bern, Switzerland. It's the largest tertiary care facility in Switzerland, where he's also the vice dean for CME. It's an extremely large department that's really at the cutting edge of everything in cardiology, including in the treatment of coronary artery disease, structural heart intervention, EP, heart failure. They do over 2,500 PCIs a year, 400 TAVIs, more than 90 mitral tricuspid interventions, and about 100 catheter ablations. I've known Stefan for many years, and I've always looked up to you, Stefan, since being a fellow, as one of the people who've really been a thought leader in interventional cardiology. Stefan's been really involved in all the European organizations when it comes to guidelines. He's been involved in the European Association of PCI and was past president in the European Society of Cardiology, and has been fundamental in many of the guidelines that we have for coronary intervention in particular, and led the myocardial revascularization guidelines in 2014. Stefan's main research interests are in both coronary and structural intervention, including looking at antithrombotic therapies. And he's really pioneered and led numerous clinical trials as PI. I've been lucky enough to be co-PI with him in a clinical trial, and have learned an incredible amount out of working with you, Stefan. So when you accepted to join us here at Monty-Hart for our Grand Rounds, I was delighted that we can continue our friendship and collaboration. And thank you for taking the time out of your day today.
Oh, thank you so much, Azim, for the kind introduction. And obviously, it's a great pleasure to contribute to Grand Rounds, particularly due to our close friendship and collaboration in many studies. But the topic I want to address today is aortic stenosis and transcatheter aortic valve implantation. And really like you to leave with the impression that it is not only one of the most important paradigm shifts in the way we approach patients with aortic stenosis, but probably represents one of the most important therapeutic advances in the entire field of cardiovascular medicine. Now, on the next slide, you see my disclosures. I do not receive any personal remuneration, but my department receives lots of funding from industry for various studies that we are undertaking. Let me start with a few words regarding the epidemiology. I think it's very clear that aortic stenosis is one of the most frequent valvular heart diseases we deal with, and that requires a surgical correction. Represents about 1/3 of the native valve disease in industrialized nations. And due to the degenerative cause of the disease, really the increase of the manifestations are in patients older than 70 years of age, and there's an exponential takeoff of 75 and 80 years. So clearly a disease of the elderly. Now, if you look on the right side, you see a diagram which may be already outdated, but provides you with an impression from the German Gary registry, where you see two peaks, the first one peaking at 75 years of age, and these were patients in the year 2010 to 2012 undergoing surgical aortic valve replacement. And then you see a second peak at 85 years of patients undergoing transcatheter aortic valve implantation at that time. And I think what this graph nicely illustrates is that the vast majority of patients we are talking about are actually aged 70 years and older. And I think this is important to keep in mind when we address later on the question on durability and lifetime management. Now, certainly the diagnosis of aortic stenosis is based on two principles. One, to look for the typical symptoms of dyspnea, exertional syncope, or angina. But the primary diagnostic tool remains echocardiography with the systematic assessment of transvalvular gradients, the calculation of the aortic valve area, importantly, the definition of the flow state, the assessment of left ventricular function, and the assessment of wall thickness and dimensions in order to arrive at the diagnosis or the correct diagnosis of aortic stenosis. And as you know, the spectrum of aortic valve stenosis is wide, where we have the typical high gradient severe aortic stenosis, but also other manifestations like the low flow, low gradient aortic stenosis with preserved ejection fraction, referred to as low flow paradoxical aortic stenosis, and then the low flow, low gradient or classical low flow severe aortic stenosis. And for all these reasons, it's important to arrive at an accurate diagnosis, which sometimes goes beyond echocardiography and requires CT imaging, in particularly to assess the amount of calcification. Now, when the diagnosis is established, the next step would be to identify the optimal spot of the intervention relative to its benefit and risk. And here, obviously, we like to determine the most desirable time, and we rely on the transition of patients coming from an asymptomatic state to a symptomatic state, classified by this classic Braunwald depiction of the three symptomatic manifestations: angina, syncope, and heart failure. But on the next few slides, I want to raise the question whether this symptomatic categorization is still timely, or where we potentially would need to require to intervene at an earlier stage. First of all, if we look at available data in patients with symptomatic aortic stenosis that did not undergo aortic valve replacement therapy, we see for the PARTNER 1 trial that there is an excess of mortality that can be halved by an intervention like transcatheter aortic valve implantation, with a number needed to treat of only 5. And on the right side, you see data of a recent observational study of nearly 550 patients that were largely elderly, but did not undergo aortic valve replacement. And what you can observe is that actually 2/3 of these patients that did not undergo aortic valve replacement in the contemporary era were potentially appropriate candidates for aortic valve replacement, and they had a very poor prognosis at 1 year and 2-year mortality of 50%. And the most common reasons were actually patient refusal, but also incomplete heart team evaluation, clearly pointing to the fact that there remain a considerable portion of patients that could be treated with transcatheter aortic valve implantation. There also have been 2 recent studies that raise a little bit the question whether we should not intervene earlier. One has been a small-scale randomized clinical trial from Korea, where patients with so-called very severe aortic stenosis, defined by a mean gradient of more than 50 millimeter mercury, were randomly assigned to undergo surgical aortic valve replacement or watchful waiting. And what we see here in the cumulative incidence for death and heart failure, and clear advantage for the intervention in asymptomatic patients with surgical aortic valve replacement. On the right side, you see interesting observational data from Australia in over 200,000 patients, where clearly patients with moderate severity of aortic stenosis, defined as a mean transvalvular gradient of 20 to 40, actually had a similar poor prognostic outcome as patients with severe aortic stenosis. Again, asking the question whether potentially we would need to intervene earlier. And finally, I want to leave you with the impression that aortic stenosis may not be the only valve disease when patients are presenting. Approximately 1/3 of patients will have moderate, at least moderate mitral regurgitation. About 10 to 20% of patients have some degree of mitral stenosis. And a large proportion of patients, also 25%, have tricuspid regurgitation. Now, the reason that this is important is that for all concomitant valve manifestations, the outcome is impaired as compared to patients that have isolated aortic stenosis. Now, turning to transcatheter aortic valve implantation, I just want to raise or make you aware that actually next year will be the 20th anniversary, and therefore it's no longer a novel technology, but rather a mature technology where we have a plethora of devices that have been investigated, although one has to acknowledge that particularly in the US, mainly the balloon expandable and the self-expanding prosthesis are utilized. But it is not only the transcatheter prosthesis, but also the ancillary devices where there has been important progress as it relates to development of specific balloon valvuloplasty devices. Importantly, the topic of cerebral protection, then advances as it relates to vascular closure, and also guide wires that are atraumatic in order to mitigate the risk of ventricular perforation. Now, prior to going into the data into detail, I also would like to contrast the first intervention that was done percutaneously in the coronary arteries, which took place in 1977 in Zurich in a patient who was actually an age-mate of Andreas Grinzig. You see, he was a true low-risk patient with an isolated proximal LED stenosis. And here you see the result in 2017, attesting to the long-term outcome. Conversely, the very first patient that underwent transcatheter aortic valve implantation was a moribund patient that was inoperable and who unfortunately died 3 to 4 months after the intervention due to the complications that were associated with an acute limb ischemia that required leg amputation. And this clearly shows you that the advances of new technologies nowadays take place in a completely different environment than they have taken place 40 to 50 years ago. Now, coming to the evidence, transcatheter aortic valve implantation is certainly one of the best studied interventions in the field of interventional cardiology. I already touched on the results of partner 1B, but if we look at the high-risk surgical patients, then we see in partner 1A and core valve high risk that the outcome in terms of all-cause mortality out to 5 years was entirely comparable between the two replacement strategies. Moving on to intermediate risk patients, we have data from partner 2A and SAVR-TAVI. Here you see the 2-year outcome for all-cause death and disabling stroke. And again, you see entirely comparable outcome data for the two replacement strategies. And finally, we have evidence from the low-risk trials, partner 3 and evolute low risk, which here are indicated for the 1-year outcome, all-cause death and disabling stroke, where you see favorable outcomes for transcatheter aortic valve implantation, again, absolutely comparable to surgical aortic valve replacement. So if we do a synthesis of all the available data available from randomized clinical trials, then we have two observations. One is that transcatheter aortic valve implantation is associated with modest 12% relative risk reduction, which is of borderline statistical significance. But what is of interest is if you stratify according to access route, then you see that TAVI, when performed by the transfemoral route, has a larger survival benefit as compared to the transapical axis, which actually shows some excess mortality as compared to conventional surgery. The other observation is that beyond death and stroke, TAVI is associated with benefits as it relates to other important peri-procedural events. And namely, there's a 50% relative risk reduction of acute kidney injury, new onset atrial fibrillation, and major bleeding. And all these adverse events have been associated with impaired prognosis among patients undergoing surgical aortic valve replacement and are therefore of clinical importance. And finally, beyond the clinical endpoints, also quality of life and symptom status are important. And if we look at the outcome within 30 days after the procedure, there you see data from the PARTNER 3 trial, then we see that patients regarding symptom status, 6-minute walk distance, and quality of life actually recuperate more quickly as compared to surgical aortic valve replacement, and difference that is no longer observed at 1 year, but certainly is important as it relates to rapid mobilization of patients. Now, all this evidence has been successively implemented into the professional guidelines. And last year, 2020, the ACC/AHA guidelines upgraded transcatheter aortic valve implantation to a Class 1A indication. And importantly, they no longer mention operative risk. Later this summer at the ESC conference, the 2021 ESC valvular heart disease guidelines will be presented. So an important paradigm shift has taken place against the background of the available therapy. First, the outcomes of transcatheter aortic valve implantation as compared to surgery are taking place irrespective to risk. And therefore, we are no longer considering, or should no longer consider, operative risk, but rather look at the age of the patient, then the anatomy and risk of complications for either procedure and comorbid conditions. And therefore, the traditional view that all patients with severe aortic stenosis should first be evaluated for surgical aortic valve replacement, and only those not suitable for surgery should be considered for transcatheter aortic valve implantation, will shift to the opposite, where actually a priori patients will be evaluated for transcatheter aortic valve implantation, and only if not suitable will be considered for surgical aortic valve replacement. Now, this transition obviously takes time, and there remain important issues which I want to address within the next half hour. Certainly, they are listed here, and they include stroke, paravalvular regurgitation, atrioventricular conduction disturbances, durability, important the issue of populations that have been excluded from the randomized clinical trials, and finally antithrombotic management. Now, if we look at stroke, then there is a biphasic risk, which is certainly front-loaded, and due to the intervention where we manipulate the valve with the associated risk of debris that may embolize to the cerebral circulation. But there's also a subacute and long-term risk that is more associated with the underlying disease state of the patient and comorbidities such as atrial fibrillation. And therefore, we need to look differently at acute stroke and late stroke. These are data from the STS-TVT registry in more than 100,000 patients, where the overall rate of stroke, including TIA, is about 2.3%. This is not a high figure, but this is a clinical evaluated stroke incident, and certainly silent stroke may be more common. Now, what is interesting in this series is that between 2012 and 2017, this rate of stroke has not much changed, but is in the range between 2 and 2.5%. And also observational, there don't seem to be large differences between patients, whether they are pretreated with dual antiplatelet therapy or single antiplatelet therapy, or those receiving oral anticoagulants or no oral anticoagulants. But certainly what will gain prominence in the future is cerebral embolic protection. And I show you only one preliminary data piece, which is in patient-level propensity-matched analysis of 2 randomized trials, Sentinel US IDE and the CLEAN TAVI study, and an observational study, the Sentinel ULM study. And in this study, the investigators were able to report a 65% relative risk reduction in the risk of procedural stroke. Now, these are certainly preliminary observations, and it's a mix of randomized and non-randomized data. And therefore, we should await data from randomized outcome trials such as PROTECT TAVR, which is ongoing and randomly assigns 3,000 patients to TAVI without filter, and those undergoing the intervention with the Sentinel device. As mentioned, late stroke is the other issue that is of importance. Here you see a multi-center study of nearly 4,000 patients, the incidence of approximately 5% throughout 2 years, with the majority of events being ischemic. And here, unfortunately, therapy is more complex because the causes are multiple, and they include the underlying atherosclerotic disease burden, underlying atrial fibrillation, but very rarely potentially also by a prosthetic valve thrombosis. Now, coming to the next limitation is paravalvular regurgitation. On this slide, you see the rate of moderate paravalvular regurgitation in the major RCTs according to risk, from the high risk, intermediate to low risk, both with the balloon expandable on the left and the self-expanding prosthesis on the right side. And what you see is that over time, certainly the prevalence of moderate or more paravalvular regurgitation has decreased. And if we look more closely at the data in the low-risk trials, then we see that in terms of moderate to severe paravalvular regurgitation, actually the event rates are rather comparable for transcatheter aortic valve implantation and surgery. However, there's a large difference as it relates to mild paravalvular regurgitation. And at this point in time, there remains controversy as to the impact of mild paravalvular regurgitation. Here you see data from the PARTNER 2A trial for, on the top, moderate or severe paravalvular regurgitation, in the middle, mild paravalvular regurgitation, and on the bottom, no or trace paravalvular regurgitation. And you see that these curves between none and mild diverge over time, and that they become significant at 5 years follow-up. We looked at our own institution in more than 1,000 patients, and we used both the conventional 3-class grading scheme, but also applied the new WARC 3 proposed 5-class grading scheme. And what you see that is in the 3-class grading scheme, there is a difference which emerges not after 1 year, but after 5 years of follow-up. And if you use the new 5-class grading scheme, this difference emerges particularly among patients that have mild to moderate paravalvular regurgitation, where it is not associated with patients with mild regurgitation. So this is certainly a topic where we need to keep further improvements in mind, keep attention to imperfect outcome, particularly when we come to low-risk younger patient populations. The next limitation are atrioventricular conduction disturbances, and this comes to no surprise because it is already known from surgical aortic valve replacement due to the proximity of the aortic valve complex with the atrioventricular conduction system. Now, there are several electrocardiographic predictors, such as AV-Conduction disturbances. There are patient factors, namely age. There are also some procedural factors, namely the implantation depth, that all are helpful to predict the requirement for a permanent pacemaker or atrioventricular conduction disturbance. And therefore, we need to carefully monitor patients after the procedure, with all patients undergoing telemetry, but some patients may require temporary pacing over 24 hours or longer. So certainly patients that have no electrocardiographic changes during the intervention and have no pre-existing right bundle branch block, the temporary pacemaker can be removed right after the intervention, and patients just monitored with telemetry. Conversely, patients that develop new conduction disturbances, new left bundle branch block, on high degree AV block, or have a pre-existing right bundle branch block, they will be discharged to the intermediate care unit with a temporary pacemaker, and the subsequent decision-making depends on the evolution, whether there is regression or progression of the AV conduction disturbances. Now, if we look at the pacemaker rates, I already have shown that there are some device differences. But importantly, if we look at the outcome of conduction disturbances being left bundle branch block or the requirement of a permanent pacemaker below, we see in these large meta-analyses assessed at 1 year that both new left bundle branch block and permanent pacemaker implantation are associated with an increased risk of all-cause mortality and heart failure hospitalizations. And here you see one of the individual studies that shows follow-up extended to 5 years, where you see that curves separate early but continue to diverge during long-term follow-up for both all-cause mortality and heart failure hospitalization. And therefore, AV conduction disturbances and the need for permanent pacemaker is an important consideration. Now, how can we mitigate the risk? I think certainly the valve type may be an option to consider in individual patients depending on the underlying anatomy. Another insight has been the membranous septum that actually can be delineated on CT scans, and careful attention to the implantation depth of the prosthesis. That is, if the implantation depth is less than the length of the membranous septum as assessed by CT, the overall risk of permanent pacemaker implantation is low. And therefore, the field is moving to high implantation techniques. You see here the outcome for a high deployment technique with the SAPIEN valve, the balloon expandable valve. You see here on the right side, the cusp overlap technique for the self-expanding core valve, EVOLUTE valve. And both of these techniques aiming at a high implant are associated with single-digit permanent pacemaker implantation rates, pointing that we make progress, but certainly need to continue more progress in this field. Now, I have shown you the outcome data of the randomized clinical trials, but importantly, we have to recognize that young patients less than 70 years of age, those with bicuspid anatomy, those with pure aortic regurgitation, high-risk anatomy, unfavorable femoral access, severe coronary artery disease, multi-valve disease, endocarditis, they were all excluded from the randomized clinical trials. This does not mean that they are not candidates for transcatheter aortic valve implantation, but means that we need additional data. Now, let me first turn to the issue of durability and younger patients. First, I think our approach in the future should be based on life expectancy and expected valve durability. We're still in very young patients, aged less than 50 years of age, mechanical valve prosthesis can be considered or a ROS procedure. Then in patients above the age of 65, certainly we would generally consider a bioprosthetic valve prosthesis. And then there is a gray zone where we require individual decision-making in the age between 50 and 65. Now the guidelines, the ACC-AHA guidelines clearly point to this recommendation based on age. And as it relates to the high end, that is more than 80 years of age, the guidelines make actually a differentiation where TAVI has a class 1 indication and surgery no longer has a class 1 indication, but actually a class 2 indication. But really the issue and question is with younger patients, that is 65 to 80 or even younger. What are our long-term data? Now, first, if you look at the randomized clinical trials, we have data out to 5 years where there's absolutely no difference as it relates to all-cause mortality and stroke. Also, if we look at hemodynamic data derived from systematic echocardiography, we see that the outcomes here on the left side for the self-expanding valve and here on the right outcome for the balloon expandable valve are rather favorable. Now here you see some differences actually in favor on transcatheter aortic valve implantation with the core valve, but this may be related at least in part to the definition of structural valve deterioration in patient prosthesis mismatch. And this has been somewhat corrected in the new set of VARC 3 definitions. And then if you focus on the new generation SAPIEN 3 device, you don't see any relevant differences in this randomized data set. Now, if we look at observational studies, we actually have data that go out to 8 years. And if we look at the rate of severe structural valve deterioration, we see that overall the rate is very low, below 5%. But we have to acknowledge that the mean age of this patient population probably was too low and that they too high, and that there was the competing risk of mortality. If we look then at the available durability from surgical aortic valve replacement, we also have a follow-up in the mean range of 8 to 14 years. Certainly, there is a long-term follow-up available up to 20 years, but all in all, the rates of structural valve deterioration that require re-intervention appear comparable to what we have available at this point with transcatheter aortic valve implantation up to 8 to 10 years. So how should we then inform our decision making? First, I think in patients that have a life expectancy that is less than the life expectancy or expected durability of the valve, clearly TAVI is preferred. That is, patients with a life expectancy less than 10 years. It is more complex in patients that have a life expectancy of 15 to 20 years, where we don't have long-term follow-up data, particularly in younger patients at this point in time. And we also need to recognize that as soon as these data will be available, we have newer generation devices that will have replaced the early generation devices. And therefore, what we really need to think about is the lifetime or life cycle management of a given patient. Now, we do know that valve-in-valve procedures are feasible both for TAVI and surgical aortic valve replacement and TAVI in TAVI valves, where the mortality is actually rather acceptable as compared to repeat surgery, and also the rates of stroke are entirely acceptable. So for the future, here you see the potential combinations that may be possible. So patients with a low life expectancy, certainly we will just perform a one-time transcatheter aortic valve implantation. Patients that have a life expectancy between 10 and 20 years, probably we start with TAVI and we may have to perform TAVI in a certain proportion a second time. There may be some patients for anatomical reasons that still undergo surgery and where we perform a second time in valve-in-valve transcatheter aortic valve implantation. And then patients with a long life expectancy, 20 to 30 years, we may have options where we start with surgical aortic valve replacement, followed by transcatheter aortic valve implantation, but we may also start with transcatheter aortic valve implantation, followed by surgery. And all these strategies have their own strength and limitations, and we need to tease out in the future how to best address the lifetime management in patients with aortic stenosis. Now, I've mentioned another patient population that has been excluded from the randomized trials are patients with bicuspid aortic stenosis. Now, I first want to mention that in both the ESC and ACC-AHA guideline, it is mentioned that patients that have concomitant dilatation of the ascending aorta in excess of 45 millimeters should be preferentially considered for surgery. If this is not the case, we have some observational data here for both balloon expandable and self-expanding prosthesis. Let's start with the balloon expandable experience from the SDS TVT registry. In 2,500 patients, you see here the outcome matched for bicuspid versus tricuspid, both for mortality and for stroke, no significant differences. Very similar outcomes you see in this graph for patients undergoing bicuspid TAVI with the self-expanding core valve evolute prosthesis, no differences in the matched cohort. However, what has been increasingly clear is that bicuspid anatomy is complex. And this is an elegant publication from Cedars-Sinai, where they categorize patients not only according to bicuspid status, but also the distribution and extent of calcification in the raphe and the leaflets. And what you see is that patients that had excessive calcification of both the raphe and the leaflet, these patients not only had an increased incidence of more than moderate to severe paravalvular regurgitation, but they also had an increased risk of mortality. So clearly in bicuspid aortic stenosis, we know that the procedure is feasible in well-selected patients, but there remain question marks as it relates to the risk of stroke, the risk of permanent pacemaker implantation. And one open question will be how to move the field forward, whether it's realistic at all to do a randomized clinical trial, for example, in patients with heavily calcified raphes and leaflets. Moving to the anatomical considerations and subsets that have not been included in clinical trials, I just want to mention that in the guidelines, the class 1 indication is for transfemoral transcatheter aortic valve implantation that have no anatomic contraindication. And therefore, it's important to consider some high-risk anatomical features. And they include certainly aortic annular dimensions that are unsuitable for transcatheter aortic valve implantation. They are considerations with patients that have excessive left ventricular outflow tract calcification, and then those patients with a certain risk of coronary obstruction. Let's start with the left ventricular outflow tract calcification. These are data again from our own institution where we quantified the extent of calcification using CT. And what you find here is that in patients that had moderate or severe left ventricular outflow tract calcification, there was a small but significant excess risk for annulus rupture. And these patients also had an increased risk of paravalvular regurgitation, irrespective of the valve design. Turning to the risk of coronary obstruction, fortunately, that risk is rather low. It's less than 1% in carefully selected patients with a native aortic valve, but it is higher, 2 to 3% in patients with valve-in-valve transcatheter aortic valve implantation. And certainly a low takeoff of the coronary ossia, less than 8 millimeters from the annulus and the shallow sinus of Valsalva are certain risks for obstruction. And then are those patients that have an unfavorable femoral axis. The first message is that transapical axis is actually an axis that performs actually worse than surgical aortic valve replacement, and therefore has not proven to be so useful and is only used in rare cases. Then we have alternative axis, but there we miss the data from randomized clinical trials. I just want to show you or make you aware of one technique, and that is electrosurgically facilitated intervention and specific subsets that are able to mitigate both the risks of coronary obstruction, but also allow for alternative access. And one is basilica, where you perform an electrolaceration of the left or right coronary cusp leaflet in order to slice the leaflet and therefore prevent coronary obstruction. And the other one is transcaval access, where you pass an electrified wire from the vena cava into the aorta in patients with poor peripheral vascular access. Now here you see one patient that has a severe peripheral arterial disease, for which reason here an electrified wire was passed into the aorta. And here you see the aortography when the large bore TAVI sheath has been placed through the vena cava into the aorta. And then this patient went on to have actually a basilica procedure because it was in valve implantation. with low takeoff of the coronary artery. Here you see the passing of the electrical fire through the leaflet, which is then captured with a lasso and then externalized, and the leaflet lacerated. And you see here the result with echocardiography, following which you can implant the valve with a nice result and nicely patent left coronary artery. And finally, the occlusion of the aorta with an MPLAT duct occluder with a complete occlusion and no further opacification of the vena cava, showing you some off-label use of patients that are maybe inoperable, but where you still have interventional possibilities to treat them adequately. Now, one patient subset that also has been excluded from randomized clinical trials have been those patients with severe coronary artery disease. And this is important, as particularly in the higher and intermediate risk patients, the prevalence of coronary artery disease was in the order of 50 to 60%, much lower though in the lower risk trials. Now, the guidelines, they recommend that we use either CT angiography or coronary angiography to delineate the anatomy. And I would submit to you that at least in the elderly patients with excessive calcification, probably coronary angiography remains the gold standard. But they also point to the fact that you should consider revascularization, and particularly in patients with severe coronary artery disease, that you may give preference to surgical aortic valve replacement and coronary artery bypass surgery. Now, there are only few data available from the SAVR-TAVI trial. Patients with coronary artery disease could be included as long as it was not complex. And here you see the outcome, TAVI versus surgery, patients that underwent revascularization in SAVR-TAVI on the left, in partner 3 low-risk trial on the right. You see that overall the results are consistent with those that underwent no revascularization. So at least the data we have from the randomized clinical trials point to the fact that you probably can do both in carefully selected patients. But what remains a concern is coronary access after transcatheter valve implantation, which is largely related to the design of prosthesis. And that is particularly with high frame prosthesis, it is more difficult to cannulate the right and the left coronary artery. And there's also an issue that may be related to the malalignment of the neocusps, which may actually be just above, in front of the coronary artery, and therefore also increase the difficulty to engage selectively the coronary arteries. Now, where this may play a role is in the setting of ST elevation myocardial infarction. Fortunately, this is rare, but here you see in small multi-center series where clearly the door to balloon time and the failure rate was increased in patients with prior transcatheter aortic valve implantation. And also the overall mortality was high. Now, we cannot say that this was related to the coronary access, but nevertheless, indirect evidence point to the fact that it may be more difficult to treat patients with STEMI after transcatheter aortic valve implantation. And this may be even more complicated when we have multiple transcatheter aortic valves in place, that is more than one valve, where the overlay of 2 frames may further increase the difficulty to access the coronary arteries, where they actually artificially create a tissue channel between the degenerated leaflets and the new valve, which could make the crossing impossible. Now, towards the end, I like to touch quickly on the antithrombotic treatment. And just like in coronary artery disease, we need to carefully weigh the thrombotic ischemic risk against the bleeding risk. And sometimes, as it relates to patient characteristics, they go along. So both age, sex, history of thrombotic events or bleeding events, They go along with both the ischemic and the bleeding risk. But then there are other issues that relate to the antiplatelet therapy and anticoagulant therapy. And the evidence base and the decision making is by far not as advanced as in the field of coronary artery disease. But if you look at the ischemic risk, and I picked it here, major stroke as the most frequent adverse event at 30 days in dark blue and 1 year in light blue, and contrast with the frequency of major bleeding at 30 days or 1 year, you immediately note that irrespective whether these are high risk, intermediate or low risk trials, the bleeding risk is in generally higher in these studies as compared to the ischemic risk. Now, this slide summarizes the data from randomized clinical trials that have been undertaken in patients without an indication for oral anticoagulation. And I'll just point out popular TAVI, the cohort A, where actually dual antiplatelet therapy, which had been the standard, was compared to an aspirin monotherapy. And what you see here, that actually aspirin monotherapy was superior for the net adverse clinical outcome as well as bleeding. Then there were two studies, Galileo and Atlantis, in patients without indication for oral anticoagulation that assessed non-vitamin K oral anticoagulants. In Galileo, that was low-dose rivaroxaban, 10 milligrams, combined with aspirin for 3 months, as compared to dual antiplatelet therapy for 3 months, followed by aspirin monotherapy. And in this study that was prematurely halted due to safety concerns, actually the NOAC-based regimen was inferior as it relates to the 1-year MACE, and there was also a trend as it relates to bleeding. And in the more recently presented Atlantis study, there were formally speaking no significant differences, but there was also a trend as it relates to mortality actually in disfavor of the NOAC-based strategy as compared to an antiplatelet strategy. Now, in this slide, you see the two randomized trials that have been conducted in patients that have an indication for oral anticoagulation. One is the popular TAVI cohort B, and the other one is the second stratum of the Atlantis trial. If you focus on the Atlantis trial, when vitamin K antagonist was compared to apixaban, we see at 1 year no difference as it relates to the net adverse clinical event rates and the bleeding event rates. Therefore, I'm leaving you with the recommendations that have been published in a consensus document of the ESC working group on and the ESC Council on Valvular Heart Disease. First, if we have patients that have no indication for oral anticoagulation, these patients will be treated usually with single antiplatelet therapy. If there has been no recent coronary stenting, they will be treated with single antiplatelet therapy, either aspirin or clopidogrel. And if there has been a recent stent, they will receive DAPT for a duration of 1 to 6 months. Conversely, if patients have an oral anticoagulation, they will be on oral anticoagulation. An unresolved issue is whether that should be interrupted or not for the intervention. If there is no recent stent, they will continue with the oral anticoagulation monotherapy after the intervention. If there was a recent stent, they will receive a dual therapy, typically consisting of clopidogrel and an oral anticoagulant followed by oral anticoagulant monotherapy thereafter. So in closing, I think what we really need to consider is also the patient's perspective. And that brings me back to my initial remark that transcatheter aortic valve implantation constitutes one of the most important advances in cardiovascular medicine. Certainly, the procedure is much less invasive. It does not require cardiopulmonary bypass and no prolonged ventilation. It is also associated, when performed by the transfemoral route, with lower mortality risk. There's lower risk of new onset atrial fibrillation and bleeding events, kidney injury, all outcomes that are important for the patient. There's also, in terms of the early recovery, shorter hospitalization and faster return to normal life, and then better quality of life. And what still needs to be determined is the long-term lifetime management of these patients, where we need to pay careful attention to the issues of coronary access, to the risk of permanent pacemaker, to the long-term durability of valves and paravalvular regurgitation, as I have mentioned previously. I'm closing here. Thank you very much for your attention, and I'm happy to take any questions you may have.
Stefan, thank you so much. That was absolutely phenomenal. I think it goes down as probably one of the best talks and overviews I've had on I've heard on TAVI, and I'm sure it's going to be watched over and over again by our fellows and by those of us who follow Monty-Hart, you know, and they'll watch the recording over and over again. So for the participants, if you have any questions, if you could type it in. We don't have any questions there. We do have a comment from Dr. Yorde, who's the head of our heart failure, saying, thanking you as well, saying it's an absolutely exceptional overview. And we also have another, you know, panelist who's another expert in TAVI, Dr. Eberhard Gruber. Eberhard, thank you for joining us. I'm not sure if you had any comments before I asked a couple of questions.
Well, I tell you, I have listened to many aortic talks, obviously, and Stefan is always surprising. To one point, it's not surprising. The other one, I mean, that was it was an incredible overview of what is current standard of care. And congratulations, Stefan. You really covered everything. Not a single thing that I can think of you've left out and confirmed by the recent data. I really enjoyed following your talk, and I would like to congratulate you on summarizing the TAVR situation in today's world. Fantastic.
Thank you.
Stefan, I had a couple of questions, and maybe I'll start. And obviously, Eberhard, please join in if you have any comments or questions. The one is on valve selection. So, I mean, in Europe, in your practice, you probably have multiple valves now that you're using in burn. One balloon expandable and probably multiple self-expandable valves. How do you make your choice of valve for a patient? Yeah. And does the age and life expectancy of the patient impact that valve choice?
Yeah, that's an excellent question. So it will surprise you, but currently we are actually using only 3 valves. And I think that's also interesting to see how the field has a little bit changed, where we had an excitement that there will be a plethora of devices, but it's not so easy to beat the workforces that are on the market. So currently we use the balloon expandable SAPIEN, we use the self-expanding Evolut core valve, and we use the Symetis valve. Now, I can tell you that probably our distribution is in the order of 60% SAPIEN, 30% Evolut core valve, 10% Symetis. And we make our selection on an individual basis. And that is, we certainly favor the self-expanding prosthesis in all valve-in-valve procedures. We also favor it in small anatomies, and that is an issue certainly in smaller patients, in female patients, where we would favor this valve due to the superior hemodynamics that we would achieve. And then there are certain patients where we opt for the Symetis valve. As you know, we did the SCOPE 1 trial, which actually showed that it was not non-inferior, it actually was inferior to the SAPIEN 3 valve. But I think it's still a valuable valve in carefully selected patients that have a little degree of calcification. And has the advantage that it is also associated with a very low permanent pacemaker implantation rate, has the advantage of good coronary access. So this is a little bit on a high level how we select these valves in our practice.
Great, thank you, Stefan.
Durability is not an issue at this point in time, I would say. I didn't address that issue. So durability at this point in time has not been a driving force for us to consider at this point in time.
Okay, great. A couple of questions from our participants. This is a difficult question, and I don't want to spend too much time on it, but I'll propose it. Any comments on subclinical leaflet thrombosis? Has the fact that we know it's out there, has it changed your practice about doing routine CTs or therapy?
Yeah, so also a very good question. So we do not perform a routine CT outside from some research protocols, and that is we do not actively search for this. Having said this, if we do observe it for some reason, accidental finding or whatsoever, we are proactive in treating it, which may not be the right approach. You could also await the spontaneous course, but usually what we do is we switch them to an oral anticoagulation. Typically, we start with a NOAC, and then we, in case that would not change anything, we would give a vitamin K antagonist. Now, I see also one question on the chat, maybe that is related regarding DAPT or SAPT in valve patients. There, I must say, our routine is to actually provide oral anticoagulation. Also in those patients that don't have an indication for oral anticoagulation, we at least do that for the first year because the risk of valve thrombosis or the risk of subclinical valve leaflet thrombosis is higher in these patients. So there's not clear evidence, but this is our practice. In case there are no bleeding problems, we would opt a priori for oral anticoagulation.
Right, great, thank you. We do the same here. There's a question from Kevin Ferrick, who's one of our EP physicians here and who's been helping us a lot with using telemetry and sending patients home on outpatient telemetry. You know, I'm not sure if you guys use these Zeo patches or these event monitors, and Kevin's really helped us set this up after in our TAVR patients, so that now anybody who has transient AV block or right bundle or left bundle who doesn't get a pacemaker, we send them out with a telemetry patch, an event monitor. And Kevin's asking, you know, what is your practice at Bern? Do you use them, or are you actually implanting pacemakers in patients who have transient AV block?
Yeah, no, that's also a very relative question, and probably you are more progressive than we are. The reason is we live in a DRG environment. That is, we are not forced, or actually we are punished in case we discharge patients too early. So our mean time of hospitalization is still in the range of 3 to 5 days, and therefore we just keep the patients on in-hospital telemetry. Having said this, this is certainly not necessary, and I would, you know, support the effort you are taking, that you discharge patients with either portable telemetry device. I think in the future, implantable devices will be further miniaturized, and also from a cost perspective will be more affordable and probably take care of that issue.
Okay, great, thank you. From Mario Gracia, he mentions there's such a discrepancy between gradient and symptoms. Why some patients experience more rapid remodeling, and should emphasis move away from only gradients and valve area before intervening?
Yeah, clearly. I think really we never questioned this classic Braunwald figure, and we all are attuned to look for these symptoms. But I think today we really have sophisticated imaging at our hands, where we probably should start early to look for cardiac damage. That is, if we find on cardiac MRI evidence of fibrosis, if we have clinical evidence of an episode of atrial fibrillation, if we see that the patient has mild mitral regurgitation or tricuspid regurgitation, all these features, I think these are all components that would drive us to not perform an aortic valve replacement, but to perform studies where we compare an early intervention versus an conventional intervention as we do it today. Obviously, the question is not so easy because we are trading two risks. One is of intervening too late, with the risk of implanting a prosthesis that is a disease on its own, it will also undergo degeneration with time, and therefore it will be important to identify that sweet spot. But certainly, I think when patients have symptoms, you can be assured that a large proportion of them already have advanced cardiac damage that could potentially be reversible if you would intervene earlier. And there are several randomized clinical trials ongoing.
Yeah, I just heard recently Marty Leon was talking about a new study, I think called Progress, that will start in patients with moderate AS who have some of these high-risk features you talk about, whether that's a high BNP or symptoms unexplainable or other valve disease. I think that will maybe help us to kind of really define this group where sometimes we're intervening too late.
Yes.
There's a question from Luigi Di Biasi, who's the head of EP, about is there data on silent cerebral MRI findings during TAVI, and does that impact your oral anticoagulation management?
Yeah, so there are clearly data regarding cerebral MRI. The problem is that you find evidence of some kind of embolization in nearly all patients, on very high proportion of patients early on, but these lesions typically resolve after a certain period of time. So currently one is uncertain as to the clinical significance. And regarding the question, would anticoagulation prevent this or not? That's a very good question. I must say, so first of all, I think for the peri-procedural risk, clearly, I think cerebral protection is the way to go. But the subacute period is also a period where probably 10%, if not more patients develop atrial fibrillation, silent atrial fibrillation. And that was actually the hypothesis for studies like Galileo and the first stratum of Atlantis to consider an oral anticoagulation. Now, both studies didn't turn out so positive for oral anticoagulation, and therefore from prevention alone without clinical evidence, I would be very reluctant at this point in time. What I could imagine, however, as a future study is that, and surgeons frequently do that after surgery, that you have a regimen of 3 months oral anticoagulation followed by a single antiplatelet therapy. I think that could be one avenue. The other one is implantable loop recorders that will inform our decision making regarding the oral anticoagulation.
Yeah, perfect. Stefan, maybe a last question, kind of one of those crystal ball questions. So, you know, we've seen, you mentioned next year will be 20 years since Alain Cribier did the first TAVI procedure. And we've seen in these 20 years so much innovation. You've highlighted some of them as far as the valves go, as far as accessory devices. If you were to look ahead to sort of 10 years from now, what do you think the biggest innovation in TAVI is going to be?
Yeah, that's a difficult question, because we are really already at a level that is very advanced. Let me put it this way: on my wish list, there still would be a lower profile catheter. On my wish list, there would be still a lower pacemaker rate, also with the balloon expandable valves. And certainly, I think we need to continue to work on the issue of paravalvular, mild paravalvular regurgitation to really match surgery. But I think finally the best innovation would be to have leaflets that are durable, that is alternative materials that not require valve-in-valve considerations. And I think the surgical field has struggled with this. There is obviously the technology with the mechanical valves, which has the shortcoming of the oral anticoagulation. But I think leaflet technology, some kind of neo material that will last as long as the rest of the human body, that would be probably a major innovation.
Yeah, That's probably, I think, a good place to end. Eberhard, any final comments before we close?
No, thank you very much. I would agree with what Stefan said. That would be on my wishes too.
Great. Stefan, thank you for an incredible talk and a great discussion afterwards. It was a real honor and pleasure to have you on Monty Heart, and for my colleagues to be able to share what I've heard so often when I've heard you giving a talk, is the real thorough overview of this topic with such insight. Thank you so much.
Thank you. It was a pleasure.